You've got your hand up, by the way, John.
Well, my background's gone now.
I was just going to say that you're not corporate, Natasha.
What's going on?
Well, what about me? What do you reckon, Ali?
Hi, Amanda.
What do you
Nice to
reckon
see
to
you.
my corporate background?
Well, what can I say? It's real
What else
life.
would you expect? I might change it, actually. That's a good idea. I've forgotten.
Do you want one of our backgrounds, Amanda?
No, so I'll just fuzz it out. It's fine. Let's just do one of my background effects. I'll do a corporate-y one.
Hey, we've got Scott as well.
Hey, Scott.
Hey, Scotty.
I'm definitely not back to front because I look back to front on mine. Have you already had this discussion?
Yeah.
Upside down on mine.
Is it?
You're that far away from me.
I could give you the whole mirror explanation I gave everyone else. If it was the real world and you turned around, it'd be the right way.
It's fine. I just assume that you guys know what you're doing and I'll follow you blindly.
Scott, never assume anything.
Right, what do you think, guys? It's 4 o'clock now. Do you think we should wait for a few more people?
You know, what's the plan, Natasha?
So the plan is I'm going to give a brief introduction. I'll then hand over to Ali, hand over to yourself, Amanda, to give an introduction, go through some basic housekeeping, and then Judith and Joanne will start their presentation. That will run for about 10 minutes, and then we have a question and answer for 10 minutes. Then Scott joins in with his presentation, 10 minutes, and then Q&A for 10 minutes. Then Ali and Judith are going to do the FCP part. Again, 10 minutes for presentation, 10 minutes Q&A, and then it comes to you, Amanda, for yours. And you've got 20 minutes for yours, and then Q&A, and then 5:30.
So at the end, for mine at the end, so I'm doing the presentation, my proper slides at the end. So what do you want me to do at the beginning, or did you want me to do the slides at the beginning? They only take like 10 minutes, 5-10 minutes. What do you want me to do?
Ali, what do you think?
We'll stick to the agenda, Amanda, if that's all right.
So I'm just introducing. So tell me again. So we're just doing it. I'll just go with the flow, and when you need me with the slides, you just shout, and then I'll do it.
So on the agenda, I put you down for 5 o'clock. So you are early, but you're more than welcome to be here. You know, for.
Well, I thought I'd just keep it quiet, listen in the background. That's all.
So 5 o'clock, yeah, there's the agenda for you to deliver your 20 minutes, and then Q&A, and then closing.
Perfect. So I was just because I haven't caught up with the world yet. I've been trying to sort out the problem on the roadmaps, whereby they've moved the personalised care link to somewhere else, and they didn't say anything. So it didn't exist as of yesterday. So we now have a new link that I need to get onto the formatters.
Gosh.
Amanda, that actually went missing last week.
Did it? Nobody told me until yesterday.
It was last Tuesday. We just thought it was ELFT running slow. So I should have said something. So
I'll tell you what. I'll put it in the chat
colleague.
box. The new link in the chat box. It's going to take a while for me to get it through to the formatters. So I'll put it in the chat box.
Thank you.
Be all right.
Okay, so I'm sure we should make a start now, because we are quite stuck for time, aren't we, and quite strict with the agenda. So shall I start off with some introductions? Okay, so good afternoon everybody and welcome to the first in a series of employers educational webinars. My name is Natasha Odita and I'm a primary care workforce programme manager at Greater Manchester Health and Social Care Partnership. So I'm going to hand over to my colleague Dr. Ali Lee to provide some introductions, and she will discuss a little bit further about the webinars. I'll run through some housekeeping and then we shall begin. Over to you, Ali.
So thanks, Natasha, and thanks everybody for coming today. This is the first in a series of new roles for primary care webinars that we're running in Greater Manchester. We're aiming to reach GP practices, practice managers, primary care network, clinical directors, primary care network managers. And the idea of these series of webinars is to develop a greater understanding about the breadth of the new roles that are coming into general practice and primary care networks. We're going to hear from our first contact practitioner colleagues, our Health Education England ambassadors, and we're going to run through over a series of 3 or 4 webinars all of the roles under the Additional Roles Reimbursement Scheme. And we're kicking off today with physiotherapists, and we've got Judith and Joanne with us. Then we're going to talk about paramedics, and we've got Scott with us today. And then we're going to talk a bit around the first contact practitioner level of practice and how that moves to advanced practice. And that is a bit of a learning curve. It's been a huge learning curve for me over the past 12 months. So it's an important learning discussion to have for potential employers as well. So that's it in a summary. Please join us for every one of our 4 webinars to come after today. This is jointly produced between Greater Manchester Health and Social Care Partnership primary care team, with Health Education England, with our primary care ambassadors, and with the GM Training Hub. So thanks everybody for joining today, and I hope it's useful.
Thank you, Ali. So just some basic housekeeping before we start then. Just to make you all aware that this meeting is being recorded. So if you don't want to be on camera, then please switch off your video. There will be various opportunities for you to ask questions in between presentations. So please just raise a hand, or you can use the chat box function to drop a question in there. And most importantly, these sessions have been designed for you. So feedback is incredibly important to us. So at the end, we're just going to ask you to fill in a quick evaluation form so that we can be better and improve. And, you know, if we're doing okay, then please let us know we are. So over to Judith and Joanne, who are going to start with their presentation. Thank you.
Hi, good afternoon everybody, and thanks for coming to listen. My name's Joanne Roberts. I am a AHP primary care ambassador, and I'm joined today by Judith Dawson, who is also an ambassador for Health Education England. Both of us work for the GM PC area, and there's also Nicola McCange as well. So you're lucky that you've got 3 in Manchester, so please use us appropriately. Next slide, please, Rob. Okay, so what's our aim today? So we want to describe what an AHP ambassador does and what we can do for you. What is an FCP? There's lots of literature out there, but it's just clarifying what an FCP is and what it can do for you. What is the potential for FCPs going forwards? There's lots of potential that can help your workforce. If you've got one, great. If not, how do you get one? Currently, there's lots of people requesting first contact physiotherapists, but we need to make sure that they are suitably trained and provide supervision accordingly. I don't want to go over Judith and Ali's and Amanda's presentations, but you will know that there's been roadmaps out. These FCPs have to be qualified appropriately. Okay, so and then we'll discuss what the recruitment options are. There are a number of models. Next slide, please, Ron. Okay, so this is a bit busy, this slide, but essentially just want a description of what we are employed to do by Health Education England. Our aim is to provide some support to Health Education England on workforce planning to support the uptake of AHP roles within the primary care, all of them, not just physiotherapy. Provide advice to the PCNs on effective recruitment and retention, and what training that needs to be in for these roles to be effective, and to help with the workforce development. We've also been in discussions with the higher education institutes on development of modules to make sure that these staff, which are predominantly secondary care by tradition, can move into primary care seamlessly and provide maximum support. Next slide, please, Rob. Okay, as you know, in the UK, musculoskeletal problems account for approximately 14% of GP consultations. This is a fast drain on resources. And the first contact physiotherapy role or practitioner role was introduced to streamline care for the patients with MSK problems, and the ultimate aim to increase capacity and improve access to primary care, but also to give another career opportunity for the first contact physio. What can they do? They're advanced practitioners within the clinical pillar of their field. Okay, so they've got extensive expertise in assessment, diagnosis, and management. They essentially are first contact, which means they see people at first point of contact, which was originally seen by a GP. And they can be accessed via the GP reception via a care navigation system, just like your other roles, like your advanced nurses do currently. The focus is on early intervention. Traditionally, they might have arrived later, which means there's increased risk of chronicity and revolving patients. So hopefully, early intervention will help with improved outcomes. And it's NHS England's ambition that every patient will have access to an MSK first contact practitioner by 23-24. Next slide, please, Ron. Okay, so what can they do? Okay, essentially, the appointments are about 20 to 30 minutes, depending on what your employment model might be. That sounds like a long time, but actually they do a lot in that time. And if they save recurrent appointments, it's a very efficient system. So they can assess and diagnose, they provide self-management advice. They can social prescribe and signpost accordingly to local groups, etc. They can give return to work advice or advice on how they can actually stay in work. This is a big problem public health wise, and clearly this would have economic benefits. Some FCPs, because they are at level 7 clinically, are able to inject and prescribe. They can refer for investigations as required directly. And should secondary care management needed, they can refer to orthopaedic rheumatology and pain. And obviously, they can refer to physio as required. So what skills do they need? Okay, it's very important that the employment of the FCPs are at a level they should be to be able to perform this. You don't know what you don't know, and it's very clinical expertise is essential to ensure that there's no risk to the patient and to the staff member and to the practice itself. Okay, so they have a minimum standard. They must be HCPC registered and have a Masters or BSc in physiotherapy. It says that in the roadmap they should have a minimum 3 years MSK. That means that that's in the field of MSK. Physios in particular generally have a rotation for a couple of years. So really a minimum of 5 years in order to be able to have a clinical experience good enough to be able to diagnose and manage appropriately these patients that may present. So again, so the Centre for Advanced Practice from Health Education England is about to be introduced from April, and all FCPs need to be accredited. So they can work towards this via stage 1 e-learning modules, and then stage 2 in practice, or they can do a FCP module that covers both stage 1 and stage 2, but I won't talk about that too much because I'll be stepping on people's toes. But what else do they need? It's desirable, obviously, that they could be a non-medical prescriber bloods and imaging, and request and interpret as required, or provide injection therapy. These adjuncts to traditional therapy is what makes them advanced practitioners, and obviously this will reduce the need to have further GP appointments because they can be all this can be provided by the FCP. Next slide, please, Rob. Okay, so they are not a fast track or self-referral into in-house therapy. They should not be providing physio. They can provide advice and exercises on the point, but it's not a physiotherapy management program or a triage service. However, many patients will see the first contact physio that have not considered this previously. This, of course, will improve the physiotherapist's career pathway, but also reduce the demand on the GPs. Next slide, please. So what actually happens in practice? Okay, so if your patient comes, and they will be care navigated from reception, and obviously you will need some education of the receptionist of the most appropriate people. But in one session, yes, 20 to 30 minutes, but they can provide diagnosis, can provide advice, the fitness to work as described, potentially prescribe medications or go to social prescribing, and give physical advice. If they get this early intervention, then the chance of them recurring patients is less. And obviously, as I said, if need be, they can refer on for different courses of treatment. Next slide, please, Rob. Okay, this is an example of a care navigation system that courtesy of Salford Trust. But we need a flow chart at reception, and obviously everybody will do that depending on your cohort of patients, or you can decide yourselves which is best for your PCN stroke practice. So essentially you're looking, are they medically unwell? If not, if they want physio, then you could essentially go direct to physio. Okay, they don't need to see the FCP, and this might be because they're a presentation of something they've had before. Would they need a medication review? Potentially go back to the GP, but if it's only analgesic and they've got a non-medical prescriber, then potentially they could provide that information. So you want to find out if they want to find out what's wrong. Yeah, are they happy to see somebody who is presenting with a soft tissue, joint or muscle problem? If you could say that this is an expert in this field, and then they will be booked direct into the MSK FCP clinic. Obviously, they would always have the choice to go to the GP if that's what they want. Next slide, please. So what's the latest information and data that we've collected? So in 2020, the CSP has put 20% of patients consulted the FCP reported visiting their GP. This is quite a small amount. This shows that actually the FCP's model is able to divert some of the MSK patients from the first contact GP into physiotherapy. 95% of the patients reported receiving self-management advice. This is fast, isn't it? And information exercises. Again, that extra.
You just popped on mute, Joanne.
Yeah, I have no idea why that was. I didn't touch it. It muted itself. Okay. Am I back on?
Yeah.
Okay, 54% of patients reported improved MSK health at 3 months. Okay, and this is by the outcome measures. And 54% had less impact of their MSK condition at work, therefore much more likely to stay at work, which gives good public health data. The FCPs themselves enjoyed the enhancement in career. So going forwards, this is good for both staff and patients. And next slide, please. There are a number of employment models that exist. Okay, generally people have heard of employed by the GP practice. This is good because they become embedded in the team. You got a consistent FCP, so you don't have lots of changes, and they're able to be involved in long-term plans. The disadvantage to the practice is that the employment terms have to be the same as for a change of a change for this, and the practice will have to cover all the study leave, annual leave. The therapists themselves essentially is lone working because they wouldn't have any peer support. They could have direct contracts with the GP. I don't think this is as common, but they can organise their own sessional rates, and the advantage of that is where they can make a mutually agreeable time depending on estates, etc. The insurance is held by the FCP themselves, but it's isolating for the FCP, and how are they going to get any cover if they're sick or annual leave? They could become a practice partner, which is good because they'll be integral to the practice and decision making. But again, there is no peer support, and they share the practice of risk. There's a model that has been adopted quite a lot is contract with an NHS provider. So the advantage of the FCP there is that they get peer support, and the training is provided and by the provider with seamless journey, so they can be from the secondary care to the primary care, etc. And the insurance and retention and recruitment is all covered by the NHS provider, but the FCP then isn't embedded in practice, and that might be what the GP and the GP practice want. Okay, and then of course there's the GP Federation, where you can get good peer support and cover. But again, the employment terms are the same as the AFC, and they need insurance provided by the GP Federation. So there are advantages and disadvantages to all models, but there are a number of models that exist that could fit to your demand and your need. Next slide, please, Rob. Okay, so what is the future? Okay, so though first contact physio roles have currently they've just been focusing on MSK. There has been a number of roles that are being used for frailty and other areas. So the expansion is on the horizon. But there are opportunities for other ARRS roles. So we've got podiatry, OT, paramedics, dietetics. Scott is on the call today, as discussed. He'll discuss paramedics, but please attend the other webinars if you want information on the other roles. That's the end of my presentation. Judith and I will try and answer any questions that you may have.
Thanks very much, Joanne. So out to the audience now, if anybody has any questions, comments, please just raise a hand or drop your questions into the chat box.
We've got a bit of a silent group, Natasha.
We have. I was thinking that.
So,
or is it perhaps taking the tea whilst they're watching? Is that what it is?
Janet's got a hand up. Janet Suckley, do you want to say hello?
Yeah. Hi, Janet. How are you?
Are you there, Janet? Okay, we've got some questions. Well, we've got a question. So how many FCPs are being used at the moment?
Okay. There was 103 requested for Greater Manchester that we know about. Do you know any more there, Judith?
No, there's 103 people saying that they want to have people in post, but at the moment we don't actually know the actual numbers on the ground.
Okay.
Thank you. And somebody else has asked, when is this service due to start? Do you mean when is the FCP? I'm not too sure on the question there, but when is this service due to start?
Central Manchester. Oh, Madaf, is that for MFT? Have you gone with MFT for provision of FCP, or do you mean in general? Because in general, that the monies are available now as part of the DARES.
Okay, I hope that answers that question. Somebody else is asking, how successful is it in practice in reducing GP burden?
So I'll give you a GP practice perspective on that one. So as part of our primary care network, we work with two really excellent first contact practitioner physios, and they're a really good part of the team. They are able to take the majority of the MSK that gets the presentations that get booked in either through telephone or online. They have evaluated really well from patients. Patients really find the holistic care that physios are able to give really great, because as we know, often MSK presentations may mimic something else. So it's important to treat the person holistically and consider their physical issues, their psychological issues, their social issues, and anything else that may be affecting how well they're getting on with their life. So actually, they're becoming, in our primary care network, a really valuable part of the team. So thanks for that question. I did see a question about training, and fortunately we've got the amazing Amanda Hensman-Crook on the call, who is leading nationally on FCP training and advancing practice training in primary care. So please stay on for that. Amanda will be doing her bit at 5 o'clock this evening.
Thanks, Ali. I think we just had another question, and I think this is about the clarification of, the FCP qualifications and the deadlines of April 2021 and April 2022. Could you just expand further on that, do you think?
Yeah, it's from April 2021 is when the Centre for Advanced Practice is aiming to start the accreditation, and it's got to be done within the year up to April 2022. So that's quite correct. So it's between 21 and 22, isn't that right, Judith?
It is. And then going forward, there will be modules available through the Health Education Institutes and the training hubs that will help and facilitate people into post.
Fantastic, thank you. We've got a question from Scott Murray. Scott, would you like to ask your question?
I was hoping not. You're going to hear me droning on enough later, but I was going to say, how do physios find the transition from secondary care to primary care, and is there anything we could do to make that easier for them?
I think we've all had different experiences there, Scott, and it very much depends on your own personal circumstances at work. But I do think observation and spending time in GP practice and with the whole of the primary care team is a really important part of integration. Not just being siloed in your own little clinical room doing your workload. I think that whole awareness of primary care is very important.
Thank you, Judith. Does that answer your question, Scott? Yeah, fantastic. Okay, so we have got a really quiet audience today, but people can still drop questions into the chat box, and if we don't get time to pick it up during this webinar, we can always come back and answer those questions. Okay, so shall we move on then to Scott Murray and your presentation, please?
Yeah, hi everybody, my name's Scott. I'm an advanced paramedic over in Bay Medical Group, which is a large general practice, now a primary care network in its own right. And I'm also a primary care AHP ambassador. I started with Judith and Joanne just coming up to a year ago now, covering Lancashire and South Cumbria initially, but as the only paramedic out of the 7 of us, I've been dragged all across the northwest, so that's why I'm here today. Next slide, thanks, Rob. So when we talk about paramedics in primary care, obviously people think it starts in April 21, and that's right from the funding point of view and from an ARRS point of view. But actually, we've already got paramedics in primary care, and we have been in primary care for some time. And the reason for this is quite multifactorial, really. But I think from a numbers point of view, other than physios, I think we're the next largest of the ARRS groups currently in primary care. So there is a role for paramedics there, and we are being used effectively at the moment. But it's just about, how do we make this safer and more systemic, and what roles are these people doing? Next slide, please. So when you think about paramedics, traditionally you think they're somebody that picks up critically ill and injured people and takes them to hospital. But actually the role of the paramedic has been changing for some time now, and the types, and that's probably been due to the patient use of the ambulance service and the fact that people are choosing to access their healthcare via ambulance services, and the workload of what paramedics see day to day on an ambulance has changed. So in line with that, the training that paramedics have had to receive has moved from a vocational route towards higher education to give them a much broader skill set and a much broader ability to assess and manage different presentations in a pre-hospital environment. So what you're actually seeing is the modern day paramedic has very good assessment skills, a very good awareness of emergency red flags, and an ability to assess patients in their home and safety net and refer them onwards to an appropriate healthcare provider, or see and treat and discharge them on scene. So actually a modern day paramedic is very different to what a paramedic was 20 years ago. And what that's meant is that paramedics have a very transferable skill set, and they can be used in a variety of different areas. And we've really seen that ambulance services aren't sole providers or sole employers of paramedics anymore. Paramedics are moving into emergency departments, they're in primary care, they're moving into offshore and remote medicine, even in secondary care wards like stroke and coronary care. Paramedics are being used flexibly. So next slide, please. So what roles are paramedics doing in primary care at the moment? And this has been the tricky bit really, because there hasn't been a national pathway. Paramedics leave in the ambulance service where they have a very defined skill set and a very defined role, and they've been moving into primary care and up to the point where they get their Masters in Advanced Clinical Practice and work as an advanced paramedic across the 4 pillars, as you would expect advanced nurse practitioner who also has the same qualification to do in primary care. There's always been a grey area in the middle where those paramedics have just found their own route. And what we're probably seeing there is a bell curve of practice where you have a majority of people that are operating safely, that have developed their own knowledge and skills, that have accessed appropriate training, and have found themselves a niche in primary care. But as with anything that doesn't have a set route or a set pathway, there will be areas where people aren't quite practicing at the level that they need to be, or maybe don't know about their known or their unknown unknowns, and that prevents risk to patients. So part of the work that Amanda has been doing and the national team is to set a pathway of what that looks like from a paramedic leaving an ambulance service to a paramedic who's an autonomous advanced practitioner. And actually that middle post, that middle first contact practice area, I've had to change this slide 3 or 4 times in the last year for the title of the post, the qualifications and what that looks like. But actually now that's been defined, that's been set by the national team. Anybody that's seen the paramedic roadmap land last week will see there's a lot of similarities to the physiotherapy one, and that includes with the title, so first contact paramedic. And these are experienced paramedics that have postgraduate experience. They've done their newly qualified practitioner program, and then they have additional experience after that where they've consolidated those core skills that make paramedics, so ability to spot a sick person, that exposure to different presentations, and then look at transferring those skills into a primary care setting. But now, so if you go next slide, please, Rob. That's going dry. So what we have now is a roadmap for primary care, which has never existed before. It's brand new. So we're in the process of trying to implement that and trying to work through some of the practicalities of implementing that in primary care. But what we have now is a roadmap. We have an educational care pathway that is very similar to the physio's one with regards to stage 1 and stage 2 sign off. We have a profession specific knowledge, skills and attributes framework, which says what a paramedic in those posts at both first contact and advanced practice should know, what they should be able to do, and who they can see in primary care. And when they're seeing them, what treatment they should be offering and who they should be referring to. So we have what we're doing there is we're filling in that practitioner's unknown unknowns. They have a roadmap to work off, so they should be able to self-identify where their gaps in knowledge are. And then we're also looking at governance for CPD and clinical supervision, how to make these practitioners, how to help them transition from an ambulance service to primary care, to support them and have them in a place where they can see undifferentiated presentations safely and effectively and reduce GP workload. And there are also resources in there for portfolio development as well, which as we mentioned, is portfolio is essential for accreditation with the Centre of Advanced Practice, which is soon to come. If you go next slide, thanks. So we are still waiting for the contracting of what the ARRS model will look like. There was an updated letter that had been sent last week, which talks about the ARRS paramedic role. I'm not sure how finalised that is, but the title has changed. It's no longer a community paramedic, it's first contact paramedic. And in that, it talks about two employment models, which are direct employment by the PCN or looking at rotational schemes. And I will touch on that briefly a little bit later. Next slide, thanks. So how does that work in practice? And what does it look like for me? So bear in mind when I talk here, I'm an advanced paramedic that's been in primary and urgent care for the last 7 years and have a master's degree. But this can give you a taste of what bringing these clinicians into primary care could do for your surgery. So I work for Bay Medical Group, as I've said. They were a 6-practice super group that then became a primary care network because we've got 53,000 of our own patients to look after. And we've got a very high care home and residential home population. And also it's an area of quite significant social deprivation, quite a challenging patient, but really rewarding patient group to work with. Next slide, please. So I was the first paramedic that came to work for Bay Medical Group just over 3 years ago. I had to develop what my day looked like. There wasn't a pathway for me, so I had to kind of work out how I fit into the existing urgent care team and how that structures and how that looks and what I see. So generally in the morning, I'll either do, I'll start at 8, I'll have an hour of doing my own lab links, stuff that I've requested, bloods, pathology. I'll spend time doing my own tasks, looking at anything that's come through to me, and people task me directly, it doesn't go through a GP. I'll then see 6 patients. That used to be face-to-face, now it's telephone or an option for me to triage them and bring them in face-to-face in 15-minute appointments, which are standardised across our urgent care team, including GPs. See those, they're undifferentiated patients that come in with different urgent on-the-day care needs, and I treat and manage them independently as an independent prescriber, which is a new development for paramedics in the last 18 months or so. Between 10:30 and 11, there's coffee, which is really essential, I think, if you're bringing a paramedic in, especially if they're going to be working across PCNs, to integrate them in that primary care team, bring them into the practice and invite them to clinical coffee times. Obviously, COVID allowing, because you don't want that person operating as a satellite without a base or people that they can contact if they need help. Alternatively, in the morning, I might have been on the duty phone as a duty clinician, taking urgent telephone triage, hospital calls, urgent path links, and that's alongside a GP, because we've got the volume of patients that 53,000 people need to be that they present with. But that could, you know, with a smaller workload, that could be instead of a GP there. And then I'll do home visits, and I think that's really the unique selling point of paramedics, the ability to go out into a patient's home and assess them and work out what's going on and try and keep them at home and avoid hospital admission. Pre-COVID, that was more than 6. At the moment, with more complex cases that aren't being dealt with over the phone, and obviously the PPE, doffing, donning, all that sort of stuff, that's about 4 visits in that afternoon, 4 or 5. But we found the complexity of patients on home visits at the moment has increased, and obviously there are challenges in secondary care that mean we're trying to manage people at home, even more complex patients at home, which makes things equally challenging. And then a similar clinic in the afternoon. So from a kind of a bang for your buck idea of what a paramedic could do in a day, that's an advanced paramedic. That will give you an idea. First contact paramedics will be able to do similar tasks and duties, but it will depend on their stage in their career and their training as to how much supervision and support they need within that pathway. And you might find that actually you need them doing more home visiting, or you need them doing more time on triage or more time in urgent care. But we're a flexible profession that can really cover some different bases in primary care. Next slide, please. So what's it done for our home visiting team? So that's not all me, that 25% reduction in visits prior to, sorry, stop me if I run over time, by the way, I can't remember how long I've got left. Prior to me joining, we had a home visiting team, which was any one of our 25 GPs rotating through into the home visiting team at a time. We'd have between 4 and 6 clinicians on a day. So that's double the amount of sessions for how much GP time that was. The patient advisors would take a call, patient asks for a home visit, it gets popped on the list. On a busy day, we'd have up to 100 visits that we'd need to do. And we just wasn't sustainable. This is all pre-COVID, by the way. So what we did, we said we need to work smarter, we need to offer more continuity, we need to increase the skill set of our visiting GPs to be more comfortable managing visits, because not many GPs all like doing home visits. And we also need to skill mix and diversify. So I was brought into the visit team as the first non-GP clinician to do that. And we started triaging the home visits. And we consolidated the number of GPs that rotated into the visit team from any one of our 25 GPs down to a team of 8 who did either GP visits or routine surgery. They didn't do any other urgent care. And actually what we found was we released GP appointment time, we increased patient continuity, and we feel like we're providing an excellent home visiting service at the moment, and I think our patients probably agree. We've since offered more skill mix in there. We've got different advanced practitioners rotating into the team. We've got 2 trainee advanced paramedics that are rotating into that team as well. So we're really trying to look at skill mix there and releasing GP capacity from home visits, when actually another clinician working at an advanced level in the clinical pillar is more than capable of dealing with most of what we see in a home visit. Next slide, please. We've already talked about ambassador roles and what we've been doing, what we've been working on. So next slide, please. Some of the outcomes, some of the things that we've been doing, bearing in mind I've been working a bit more in Lancashire, South Cumbria, but our ambassadors here in GM will be doing very similar things, especially stuff around knowledge brokering and offering recruitment support, even things down to like shortlisting. If you're thinking about which applicant, I don't understand the qualifications of this applicant, are they right for me? Should, get in touch with us. They're the sort of things we can help with. We've also been looking at peer support networks. We have a paramedic Northwest peer support network. There's about 18 of us in there, and we're looking to try and extend that across the patch and think more about that as an option for different first contact roles as well. Certainly the dietitians are thinking about it. We're developing a new website with a list of resources and useful documents that clinicians and employers can access. We're developing some one-page sells. So really, what are the selling points of each of these? Why would I pick one AHP over another? Or which group of AHPs? How can I best make these AHPs work for my patient population? We've been working with training hubs and also with MWAS as well. They have 2 rotational pilot sites at the moment, looking at how they can offer a different employment option to direct employment, and have clinicians that work both in ambulance service and in primary care. Obviously, the roadmap has just landed, and at the moment these are quite small scale sites, but we have an MWAS contact if that's something that you would be interested in, that we can put you in touch with. So please let me know. And obviously, when they look at that model going forward, they can talk to you about different options there. And also looking at placement capacity as well. So we're trying to look at the pathway from student paramedic to advanced paramedic in primary care. So we're offering students on undergraduate courses placements in primary care to make them see it as a destination of employment rather than a retirement option, which I can tell you it absolutely isn't. Any paramedic that thinks primary care is an easy option and just see coughs and colds couldn't be more wrong. I used to have hair before I started in primary care, and this is what I look like now. It's been an interesting transition, but I absolutely love working in primary care. I think it's something that I think we need to do right for paramedics, and all these national processing pathways we have in place now. Everything seems to be coming into place to make that happen. Next slide. That's great. So, any questions there? I'm not sure how long that was then.
That was excellent, Scott. Thank you very much. Yeah, you were bang on time, to be fair. The floor is now open for questions. I wonder if we will have some questions from the audience. There was something in the chat, but I think you covered that, Scott, and it was around models of working, obviously, so we don't destabilise NWAS and the paramedics that are there. There was somebody talking about job descriptions as well, and I think that is something that you covered. We are still awaiting an update from HEE, but actually we've got Amanda Hensman-Cook on the call, so maybe you would like to respond to that.
Hi, yeah. So the JDs have actually come out from NHS England, and I think that the new one, what's the health platform that they use there? The
e-learning for health.
No, it's not. No, it's not Health Education England. It's published on. It's NHS England, but there's a paper that I'll pop into the side box that has it on. That's the AHP multi-professional piece that Thomas Curley's team has. I think somebody just done that. I was just reading the chat box itself. They had it there. So they've already got they're all published in that document as well as on the website. So I'll make sure that both the website and the other documents on the side for you.
Thank you. And I think Ali's very helpfully uploaded in the chat box as well the paramedic roadmap to practice and some other useful links. And Carol McRae has also uploaded some useful information as well to support. Still no questions from the audience. Okay, so
sleep with my dulcet tones, probably.
I think you've just covered everything perfectly, Scott, and everyone is now fully au fait with a paramedic in primary care, and hopefully everybody's going to run out and snap them up, but not destabilise NWAS. Okay, so we're going to move on then to Dr. Ali Lee and Judith Dawson, who are going to explain a little bit more about FCP and ACP, if that's okay.
So I'm going to do my best to share just a bit of learning I've done over the past 12 months. So I speak as a GP, but also as an educationalist. But we'll hear from Judith and Amanda in much more eloquent detail. But what I've learnt over the past recent months is that FCP at the moment, for us in general practice, means first contact physio. But actually, the FCP, the first contact practitioner, can cover all registered professionals. So all AHPs can be an FCP, and it actually relates to a level of practice. So that was the first bit of important learning. And the other bit has been touched on in presentations where it's important to recognise that general practice is a specialty. It obviously looks after people from cradle to grave, is a holistic specialty, and you need a high level of generalist skills, which means high level communication skills, clinical problem solving, management planning, and managing risk and uncertainty. And that transition from another care setting to primary care needs to be supported through education and training. So Health Education England have recognised this and have developed the roadmaps to practice, which outline the the knowledge, skills and attributes colleagues need to demonstrate before to show they achieve the FCP level. And the other thing that we've done in Greater Manchester over the past few months is go out to market for an expression of interest for a primary care specific FCP module run by our local GM universities. And we can share today that both Manchester Met Uni and University of Salford have been successful in developing an FCP module and to fit with the timelines that are associated with the Additional Roles Reimbursement Scheme, where for a colleague to qualify for the reimbursement, you have to have started an FCP course by April 21. We have put an expectation on our local universities to have that ready by April 21. So when we've got a bit more detail with you about that, when it can all start, when it can kick off, and the support packages associated with that, we'll share that out to colleagues in GM and obviously everybody on this call today. Judith, do you want to share any further thoughts?
Yeah, I think it's very important that people do recognise that it is a level of practice and that not every physiotherapist is going to be primary care ready. And my personal experience is what has been predominantly in secondary care, working in an MCAS service, screening for serious pathology in MSK. So I've got a high level of expertise and knowledge of that, but those patients have previously had some sort of differential diagnosis prior to coming to us. So working in primary care requires a little bit more than that and a little bit more awareness of what else is available in primary care. So I'm very fortunate that I've actually been on a health education FCP accredited module and had primary care experience and sign off by being supervised by a GP mentor. And that did require a lot of effort by the GP to supervise me to make sure that I was primary care ready. There was no question in his mind that I was MSK ready, but the primary care element is extremely important. And I think that's where everybody on this call really needs to recognise.
Fantastic update there from Judith and also Ali. I'm scared to ask the question, but I'm going to go out to the audience for questions. You know, if you don't want to switch your camera on or put your hand up, you know, the chat box is there if you want to drop anything in. Oh, and Amanda's just dropped us in some information there that she discussed earlier on about AHPs in primary care, so that's really helpful. If there are no questions then for that section of the webinar, shall we move on to Amanda with her National Primary Care update, please?
Okay.
Thank you.
Can we see this? Anybody?
Yes, we can.
Oh, that's good. Thank you. So when I put it onto presentation mode, can you just let me know I'm on presentation mode, please?
Yes, you are.
I'll see that. That's fine. Okay, thank you for inviting me today to speak about. So what I thought I'd do is I'll just give an overview on all 5 professions that are moving in with the Additional Roles Scheme. I guess the most important message is that it's standardised across all 5 allied health professions that are coming in. So that means the physios, the paramedics, dietitians, OTs and podiatrists. I just wanted to elaborate on where FCP sits in terms of where they are in terms of level of practice. So if you see the box on the left hand side, you've got the circles with a Venn diagram in it. So in the Centre for Advancing Practice at Health Education England, we recognise 3 levels of practice: enhanced, advanced and consultant. So an enhanced level of practice is somebody who has done a preceptorship, so they've done their degree, they have come out, they've registered, and then they do some work for a couple of years maybe, and then they might specialise in something, or they just become more experienced if it's a more generalised role, and they might go for a band 6 job. So I'm just going to use banding just for now, for people who know me, I don't usually talk about pay bands because that's just the amount of money that you take home at the end of the month. But if you link it to capabilities, it's about what you are paid in recognition of the capability and level of practice that you're working at. So in the context of that I'm talking about this now. So you've got your enhanced band 6s, and you've got your advanced level of practice, which is working at master's level across all 4 pillars of practice. And you've got, in the middle of the two, you've got a crossover in the Venn diagram. So obviously you don't go to bed one day enhanced and wake up the next day advanced. There's a bit of a process and a learning journey along that. So if you imagine on a timeline on the left hand side of the enhanced circle, you come in there, you've done your newly qualified preceptorship, you come in and you start working, and then over the next 2 or 3 years you start developing your experience and pick up a few master's modules maybe, and you learn about the systems and you're developing your skill set, and then you're coming towards the advanced realm of working clinically in a master's kind of level of practice, and that's where FCP sits, and they're the band 7s on the additional roles scheme. And then you start there, and that's the entry point for the advancing practice pathway. So once you're in FCP, you can continue through in a portfolio route through to advanced practice across all 4 pillars of practice. So what is an advanced practitioner? So if you move your eyes to the right hand side of the screen, again, there's another lovely Venn diagram. I do like drawing those, as you can see. So your 4 pillars are clinical education, research, leadership and management. And again, they're not separate pillars of practice, they're all interwoven. So what that means is that a clinician, if you're in a clinical setting, when you are seeing a patient, you're not just thinking clinical, your experience across all 4 pillars of practice is drawn into one clinical intervention that makes a big difference to the clinical way that you're dealing with that patient. You're looking outside clinical, and you may be looking at how it might affect population health, and you might be thinking in your head, well, that's interesting. I've seen a pattern amongst condition X that I've been seeing. Maybe we need to audit that to see if we're doing it the right way. And it's about educating people around you within your scope of practice. So even though the FCP is working at master's level clinically, they haven't quite topped up to master's level of practice across all 4 pillars of practice yet. So there's a slight difference between the two. So in terms of the standardisation not only is across the 5 AHPs moving in, so they have the same training pathway, same level of practice, the same supervision structure, same governance. But the really important part is it aligns with GP training. So we're really fortunate that we're allowed to use the toolkit that the GPs use, the work-based placed assessment for stage 2 of the FCP training, which is the moving of demonstration of academic knowledge into practice. And because of this, our GP colleagues now understand how the individuals are being trained. They understand what level of practice they're working at, and they're able to support them because they've been through a similar practice themselves. So they understand what the supervision requirements are to be verified and recognised along the portfolio route. So this is just, like I said, it's the same training pathway for all of the AHP professions. So you've got your pre-registration degree, which we have in Health Education England, made sure that we've now got inclusion of placements in primary care. It's really important. And I'm looking at that at the moment with regards to undergraduate placements, making them multi-professional rather than just uni-professional. So what I mean by that is sometimes if you're a physiotherapist, for example, you might go out on a musculoskeletal assessment. So if they went on a musculoskeletal assessment as an undergraduate in primary care, I'd expect them to go in, they'd still be looked after by the FCP or the advanced practitioner as their named supervisor. But I would hope that in that placement, they'd have a chance to sit with the paramedic and the OT and the podiatrist and the GP and the pharmacist. And maybe once they're learning their diagnostic skill set within primary care, because that's what's really, really helpful with these diagnostic clinicians, is that they know how to assess and diagnose and look outside the box from just what they're looking at with MSK, for example. They can then go in with the paramedic, or they can go in with the nursing colleagues, say there was a year 3 student, And when their MSK patient comes in, they can do the MSK assessments. The multi-professional team learn about the MSK assessment at that level of practice that the physios learn, and then they're observing the other professionals about the areas of scope of practice that they're working, and they learn from them. So it's a symbiotic relationship. And when you look at the advance in practice and you come to the other end when you're an advanced practitioner, you've got to remember that they're working multi-professionally, cross-sector, cross-boundary. So it's a really good formative way to start the education, looking at all 4 pillars of practice from the very, very beginning, because you'll end up with a really good advanced practitioner at the end of it. So now they've registered, they're in the ether. So here it says minimum of 3 years, but I'm going to explain that a bit more. So with MSK, it's a bit of it's the odd one out of the 5, because it's a specialist area of practice rather than having a more general scope of practice. So with what it means with them is that you'd expect a physio to have a broad base of knowledge. Going back to the primary care, it's really important that you're not just MSK focused, that when you're going into postgraduate education and into the clinical world, it's important that you touch base with all areas: respiratory, neurology, mental health. You work with the community teams, you learn all the different pathways. But then, so when you go into MSK, you then have that really broad base of knowledge that influences your MSK assessment, and you've got an understanding of all of the pathways. And then it's a minimum of 3 years in MSK before you start the primary care training. For the other professions, if we took at paramedics, since we're talking about paramedics today, we're talking about the newly qualified preceptorship for a couple of years, then working for 3 years, dare I say it, at band 6 out in the ambulance service, and then moving through into the primary care training. So the primary care training is exactly the same for everybody. You've got a portfolio route and a taught route. The taught route contains everything that's in the portfolio route in the roadmaps. It's the same knowledge, skills and attributes documents. It's the same e-learning modules, of which I've popped the correct link into the side for those of you who are wondering what's happened to the personalised care link. I do apologise for that. It just disappeared out the ether, but we've got a new one now. So it's exactly the same thing. So the way that that's supported, I'll talk about briefly later with supervision for the portfolio routes. It's not just normal supervision, it's supervision and verification of a portfolio of evidence. So the supervisor signs them off to say that they're working at a master's level of practice. So you'll see in the portfolio route, it says stage 1 and it says stage 2. So the stage 1 part is done before they move into primary care. And that's cross-referencing against the knowledge, skills and attributes document across the domains there, developing a portfolio of evidence to show that academically they're working at master's level. When they move into primary care, it's the stage 2 needs to be completed in practice. That's showing that academic knowledge that you've gained at master's level, you're able to apply that into practice, and that's the work-based placed assessment toolkit that I was talking about, that the GPs are familiar with. And the supervisors can also be AHPs, but again, I'm going to talk about that towards the end. But again, both stage 1 and 2 in the level 7 modules, which means that at the end, they're popping out onto the directory, the Health Education England directory, as an FCP. So I explained before that FCP is definitely attaining a master's level in the clinical pillar, but they don't just do that in the knowledge, skills and attributes document. When you cross-reference the domains, a few of the other 3 domains, the topped up. So if you imagine like, you know, one of them game shows and they've got those tubes and they've got coloured waters in. So like if you've got blue water in your clinical pillar, that's at the top. But your other coloured waters will be varying depending on your experience and where you've come from, but they won't be at master's level yet. So there's a top up in both of the roadmaps that have landed, and the ones that are coming will be exactly the same. That shows you what the gap is, so that you continue with focused CPD within the workplace, and you can continue along to be an advanced clinical practitioner. So new roles here. The reason I put these up is to remind me of all 5 roles, because I've got this horrible habit of leaving one out, and I don't know why. I think it's because there's 3 P's in there. So I've put MSK rather than physio there, so I didn't have 3 P, so I don't get us confused. So these are all the same things, but it's about the scope of practice. So the reason that we can have the same training pathway and the same standard of practice, the same supervision, same governance, is because there's a central core throughout all of the professions that is the primary care core that's exactly the same for everybody. And in Health Education England, we've identified what the advanced practice primary care core is, and the core credential is, it's on its way to being completed, but it sits within the knowledge, skills and attributes documents, and it's exactly the same. So it's not the superpowers of each of the individuals, it's about what makes the primary care generalist specialist. I heard Ali say that, you know, it's a speciality being in general practice. People don't really realise that there's a whole skill set that's different, which is why it was really important to put a standard of practice in to keep our patients safe, because it's really, really different when you're moving from community care and secondary care into primary care. It's like a whole different country. And I know that because I've worked across the whole system. And when I moved into primary care, and like Scott said, I actually, you know, this is a wig. Scott says he's going bald. It's like, you know, it is a whole different world, but it's the most exciting, wonderful place to work. But it does require a different level of governance because of the way that you're working. So the paramedic roadmap's landed. It's really clear what the capabilities are that are needed in there. Under the knowledge, skills and attributes document, in the last two appendices, there's all the presentations, and it says exactly what it is that a paramedic's expected to do and what in each of the presentations. In the MSK roadmap, it's really clear within there because it's the IFOM standards that run through the knowledge, skills and attributes documents. It's clear what their scope is. So the other three that are coming out, so the podiatry scope is going to be foot viability, it's going to be dermatology, obviously MSK, and it's about diabetes and frailty. Occupational therapies around frailty, mental health, activities, daily living, social prescribing, keeping people at home, around all the DWP stuff. So that'll be their scope of practice. And the dietitians around gastro, it's diabetes, it's around frailty, and it's around weight management, supplements, and it's about lots of preventative care, preventing them to get that they can manage conditions that would normally be seen in community and secondary care, trying to keep it into primary care. But these roadmaps will be coming, and it will be a lot more clear when they arrive. So in terms of timelines, obviously the MSK landed in October, the paramedics landed last Thursday. The podiatry's done. It's in a final draft form, but we're going to land it in February, back end of February, and the dietetics one and the OT one are on their way. They're actually working together as a team on this, which is really, really nice to see the multi-professional working. So the reason that we're doing it in steps rather than all at once is because it works better for the system, I think, to land something, allow it to embed, look at the teething problems for that specific roadmap and answer all the questions, and make sure that the support's there around the individual professions and around the GPs who've got these people moving in. And then the next one comes and we do the same process, and the next one, the next one, the next one. So by the end of spring, all of them will have landed into the system. So just finally, I talked about supervision, and I know that Ali went on to, she's one of our national supervisor trainers, as is Scott. They finished their course last week, so they're able now to train supervisors. It's different to what we know as allied health professions as supervision. We're used to clinical supervision, we're used to CPD supervision, and it all sits in there. But this supervision, the 2 days that's bespoke to the roadmaps for the portfolio route, is different because it's about supervising and verification of evidence to master's level. So the supervisor has a responsibility to the clinician, and there is an accountability to the clinician as well, because they are signing off FCP in practice. And then they go on and they continue to look at the portfolio route and verify it as it goes along to advanced practice as well. And then that gets looked at by a panel, either within primary care or within the centre, if they're going the top up part, if they're continuing along through the centre's advanced practice portal when it's available. Then they will then get signed off then by a panel of people, because it's really important for advanced practice at the back end, against all 4 pillars of practice. When you've got the master's route and the portfolio route, we really want to make sure that it is an equivalence to it, so that we can maintain governance around these roles and quality of standard. So I think that's it for me. I shall try and do that, and then I'll dive for cover.
Thank you very much, Amanda. That was very comprehensive and informative as well. So I have a question in the chat, and it's basically 2 FCP physiotherapists are already working towards their MSc qualifications. Do they still have to do the FCP module and start? Do you want to elaborate on that? You're on mute, Amanda.
Always one, and it's always me. I do apologise. It depends what you mean by the MSc modules. If you're talking about ACP MSc modules, the answer is yes. And if you're talking about the MSc, did you say modules or masters? Hang on a minute.
Masters. So
the masters. If it's ACP, yeah, ACP masters, the answer is yes. Unless you've pulled in an FCP module, so you've done the primary care training. So if you haven't pulled in a primary care FCP module, which probably most people wouldn't have done yet, but now's the time to start exploring that with the university, then it's all done in it. And the credits that you get from your FCP module will count towards your master's degree. So that's a nice tidy way of doing it. Otherwise, when you pop out at the other end, you just need to cross-reference your ACP master's programme to the knowledge, skills and attributes document across the whole of it, not just the FCP part, and then we can make sure that that's done. And then you still need to do the stage 2, which is good practice anyway, to do COTS and SEPs and case-based discussions. It's a really good way of proving your currency, so that when you go when your HCPC registration comes up and they ask you every year whether you're current, then you can hand on heart say you're current, because you've got a portfolio of evidence to prove that you've done that. So it scratches everybody's back as well. So and exactly the same with a normal MSc as well. Then if you haven't got primary care in it, then you will need to do the primary care training. And also retrospectively, everybody who's in practice now will also need to retrospectively do the training, and I count amongst that bunch. So I'm working through because my master's degree isn't advanced clinical practice masters. I'm actually a consultant physio, but I thought it'd be really good to go through the process anyway. And so I'm going through the portfolio route to AP at the moment as well, and I'm actually quite enjoying it because it's focused CPD.
Excellent explanation, thank you, Amanda. Ali, did you want to contribute?
I thought of a couple of things that have now flown back out of my mind, Natasha. But I just wanted to say, I think where the roadmaps are coming from is to make sure that our colleagues who are joining general practice and networks in the new roles under the ARRS scheme have had a prescribed level of primary care training to ensure they're primary care ready. And that's the purpose of the roadmaps, and then that's the purpose of the certification and verification, the stages. And that's why specifically in GM we've created FCP specific primary care modules, so that it speaks to the roadmaps, it's fit for purpose, and actually people come out ready for that supervised practice. We do recognise, though, this is Rachel from the Robert Derbyshire, that people are still already working at this level. We do recognise there's a catch-up bit to happen, and we are still a bit unclear of the documents and how it's going to work, but that will be coming out very soon, and it's all based on the roadmaps, and then it's all gets signed off through the Centre for Advancing Practice. Rachel, do you want to come in?
Yeah, if you don't mind, thanks, Alison and Amanda, that was really helpful. So if I just get my 2 physiotherapists on this module starting before April 21, even though they're already working as first contact physiotherapists, if I get them to do that module, that's a really good start. And then we can work through anything else. Is that?
Yeah, it is a really good start. But if they do the module, then they're completely signed off to FCP because stage 1 and 2's in it. So that would completely cover it. But I would suggest that the portfolio route's probably better for people that are more experienced clinicians. Now, if your clinicians that you're talking about have master's modules or a master's degree, it might be worth them just going through the portfolio route because their master's modules or degree will cross-reference across a lot of domains all at once. It will just like green light for go for a lot of the statements in a lot of the domains rather than going through an FCP module. The FCP modules I would suggest for people that don't have any master's modules or they don't have any MSc experience.
I understand now. That's really helpful. Thank you ever so much.
And I think that may have answered Janet's question. Janet was asking whether it's a portfolio route or an FCP module taught route. So it's one or the other.
Yeah, it's one or the other. You can choose, and both of them have exactly the same content in them, the same level of practice. It just gives more options for people to have a choice of whether they have got time and capacity to go on a taught route. And for the really experienced clinicians, really they should be able to, if they're working at that level of practice that they believe that they are, then the portfolio route really shouldn't be an arduous thing. It's literally just focus CPD for the bits that are missing.
Thank you. We've also got a question from Joanne Roberts. Do you want to come in? You might be on.
Yes. It says I'm off. Am I on now?
You're okay.
Yeah. Okay. So it's not so much a question as a clarification, because I've worked with Amanda before. It's just to really stress to everybody on the call. There's lots of confusion over the education of the FCPs in primary care, and Amanda obviously and Alison has explained that really well. That really you need to, anybody who's going into FCP should have completed the stage 1 modules before they start it. So and if they're in there, they need to show evidence that they've completed the stage 1 modules. Is that right, Amanda? And then develop onto the stage 2 either by gathering their evidence. But I think people are a bit scared about this, but actually, like you said, if they're already in practice, they're already doing it, they should have this experience to be able to cross-reference.
So don't worry about it. I am aware that we're building the aeroplane as we're flying it, okay, and there are a lot of things that are coming out pretty imminently that are going to help you with the stage 1. So there's something, if you're an MAC, for physios, if you are a full MACP membership, that means that your stage 1 is completed apart from your e-learning modules. The SOM, which is the other big group of people that might be out there who've done the diploma, that's being cross-referenced by the SOM now. There's a very small amount that isn't signed off on stage 1, which is around the management part, that they will explicitly give me those domains that need to be topped up so that I can get the intel out there. But it's pretty much signed off stage 1 as well. You've obviously got to do the e-learning modules because everyone has to do those. And with paramedics, if you've done the college diploma, then that will sign off stage 1 as well once you've done the e-learning modules. So what I mean by that, it doesn't exempt you. What it means is that is a credential, if you like. So that is a area of learning that's been accredited or approved or validated. And because it cross-references, because that cross-reference has been done to stage 1, it means that you've already completed that, so you're able to move into primary care. It's really important that people do the stage 1 before they move into primary care, so that you can prove that you are working academically at master's level, and the stage 2 part in primary care is the part where you prove that you can put that into practice.
Thank you, Amanda. And Ali's just dropped in the e-learning modules for stage 1. Really helpful. Judith Dawson, did you want to come in?
Yeah, I just wanted to talk a little bit about the supervision that will be provided across Greater Manchester as well. Health Education England have been providing some training for physiotherapists and GPs to be supervisors using the RCGP model and toolkit to help with the portfolio development. So it'll be very important that people do have somebody who is a recognised accredited HEE supervisor.
Yeah, thank you. And so that's really important. I can give you an update on supervision, which might help as well. So we've the reason why physios were trained as a trainer and the physios have been with the courses, these courses are the same, they are multi-professional courses. It's just that we pump primed physio because we landed the roadmap in the same way as we just pump primed the paramedics. The trainers course that Ali was on was full of the paramedic trainers, and that's going to be pump priming those because of roadmaps, because the next cohort are your regional trainers. So it's the trainers that are delivering the supervisor courses, so that's coming. And then we will be doing in March and April, there'll be 2 more cohorts. So there'll be 70 recognised national trainers across the country. So what will happen is that when we've had all the cohorts, those trainers' names and contact details will be sent to all the regional training hub leads, and that's your resource. Okay, so you'll be able to tap into that resource to be able, if you wanted to run more supervision courses, because we're pump priming each region anyway for the number of AHPs that are coming in, that money's there in your region already to make sure you've got enough supervisors for the number of workforce from the workforce returns that we've got for the allied health professions coming in now from April. So that's that part. But I know that the training hubs, if they've got spending, they're really quite keen to make sure they're running more courses. So we've got a resource of trainers that are nationally recognised to do the recognised course so that the supervisors are recognised. So I have a trainers directory, so I know exactly who the recognised trainers are. And then we have a supervisors directory. So at the end of each training course, there's a link to a supervisors survey that the cohort go onto. So that goes onto a directory. So when someone goes to the portfolio route, what happens is the clinician will fill in details. The supervisor will fill in details. So the supervisor says who the clinician was, the clinician says who the supervisor is, and then it gets triangulated to the trainer so that we know that it's absolutely come from a Health Education England trainer, so that we're maintaining that quality of supervision. And it will cascade quite quickly over the next few months. So don't worry, it is coming. And you can get hold of these supervisors, but just bear with if you haven't got them out, you know, if the dates aren't done next week and you don't know when they are, don't worry, they'll be there from March.
Oh, fantastic. Thank you again, Amanda, for the update. Judith, no, yes, Judith, I think that is a legacy hand. Thank you. Oh, Ali wants to come in. This is a great discussion. Thanks, Ali.
Just to change the focus slightly, but just whilst we've got colleagues on the call from practices and providers, just to say how key workforce returns are and your NWRS submissions. I know it's monthly now, and I know it's an extra job to do specifically in this time when we're absolutely bombed out in general practice and primary care. But loads of resources are now based on the nationally reported numbers. So our supervision quota and funding is based on the number of people we need to train, and that is identified via our workforce returns. So that resource to train the supervisors depends on practices and providers doing their workforce returns. Our CPD allowance for our registered professionals, our nurses, physios, pharmacists, paramedics, podiatrists, dietitians and OTs and others is again based on our NWRS submissions. And this year we've been in GM, we were underestimated by a few a few thousands of pounds because our data was inaccurate. So our CPD allowance is based on our workforce returns. So just a plea, amongst everything else that we have to do on our job list, our workforce returns and our submissions to the centre actually in the end come back to how much resources we're given. So that's just a bit of a from the workforce team.
Excellent, thank you. Oh, we've got a question from the audience. Thank you, Andrea. If you want to come in.
Hi everyone. Sorry, my camera's not working. It was just about that plea, Alison, around workforce returns and practices. I've still got practices in central Manchester struggling to input. And there was somebody available there was two people available from NHS Digital for that team to be able to help and support. I don't know if that's been withdrawn, but I've not heard back, and I've chased it a couple of times on behalf of her. I've got 30 practices and a handful are telling me they're still struggling. Is there a resource to be able to send people to these days?
We'll certainly find one because we've got a number of practices. I think it's 50 in GM that still haven't logged on at all. So we absolutely recognise that support and help is needed. So Natasha, can we take that back to our team, please?
Absolutely, I'll pick that up.
And Andrea, can you drop us an email, Natasha and I, as a reminder, please?
Yes, certainly. You want the thread who was who from NHS at the point? That was before Christmas.
Sorry, we couldn't hear that, Andrea.
Sorry, am I breaking up? I can certainly send you the thread. Do you want it through to Alison and Natasha then? Yes, I'll send you the thread.
Thank you.
No worries.
Thanks very much. Yeah, we'll definitely pick that up and respond to Andrea out of this meeting, out of this session. So I had Parina Kapoor, who just wanted to come on and talk about the ex-paramedic that they have working with them. Are you still available?
I am.
Hiya.
Hi. Hi. So I work in Salford, GP there. We have a paramedic who applied through to the advanced practitioner route in Salford, which programs run through by SPCT that we've got there. So he was a senior paramedic, decided he wanted to be an advanced practitioner in general practice. So he did a program which involved 2 years of being with me in general practice for 2.5 days, and then sort of university time with SPCT Salford for training. So he's covered all his general practice. So he's done a 2-year course. He's got his prescribing through that course in 2 years. And I was just concerned that your flowchart, the program you'd had before, was saying it was going to be a 3-year training, yet these people are going through as advanced practitioners in 2 years. And to be quite honest, I'm going to say he's absolutely brilliant. So we've kept him on. So having completed his training, we employed him because he is just so good.
Okay, Scott, do you want to come in?
Yeah, I was just going to say, hi, Parina. That's really nice to hear that, good examples. And we're always after case studies as well as ambassadors. So if they want to write that up, we could share it a bit more widely. The first contact route is a different route through to advanced practice. The advanced practice route direct for paramedics is still an option to access the experienced paramedics moving into primary care as a trainee advanced practitioner directly onto a full master's programme that is either 2 or 3 years, depending on the university, to then come out at the end as an advanced paramedic or an advanced practitioner. That's a different route and leads to advanced practice accreditation with the centre rather than first contact practice accreditation. And interestingly, the new guidance from NHS England suggests that advanced practitioners are going to be a new reimbursable role moving forward. So that would be a different route or a different option for the PCN. But either way, it depends on how much appetite that paramedic coming into primary care has got to study. or any of the new AHPs, do they want to put in the effort to do the full masters, or would they rather do a modular approach? They have different options there, which is quite exciting.
Wonderful, and thanks very much for sharing that, Parina. Judith, would you like to come in? You're on mute.
I just wanted to ask Scott to clarify. Somebody who's doing an advanced practice degree as a paramedic might not spend much time in primary care. So therefore, if they wanted to be a first contact paramedic in primary care, they would still be required to sign themselves off as in primary care. Is that right, Scott?
Yeah, so to register with the centre, they would still have to do their stage 2 sign off, I'm guessing, if it wasn't primary care specific, where they'd done their advanced practice masters. We still need those transferable skills. So yeah, that's a good point, Judith. Thank you.
And that is the same for physiotherapists. There's lots of advanced practice physiotherapists who've not got primary care sign off, and they have to match against both things, don't they?
Thank you. Great debate, and thanks for clarifying that as well and picking that up, Judith, and thank you, Scott, for your response. Well, this has been wonderful. I've really enjoyed learning more about you know, FCP, ACP and all of that stuff. Great. I just want to remind everybody that this is the first of a series of webinars, and our next webinar is scheduled for the 16th of February, and it focuses on dietitians, occupational therapists and also podiatrists. So I just want to obviously promote that, and if anybody hasn't already got a meeting link, you can always drop your email into the chat box and we can send you out an invite for that. So I suppose just closing our conversations and our discussion today, I'd like to hand over to Ali to see if you have anything more to say, some closing comments.
So I think my closing comments are, I'm really grateful to Judith, Joanne and Scott for joining us, and Amanda giving us the national view on first contact practice and advanced practice. My reflection is that actually this is we might need to do this again, because it's a complicated area. It's fastly moving. We don't have, as Amanda said, this is an aeroplane. We're building the aeroplane that is already flying, which is a risky place to be. So I think over the first quarter of 2021, we're going to actually see quite a lot of changes. So I think we'll need to revisit first contact practice and advanced practice again, and what that means for people on the in practice, in GP practices and primary care networks. I think we should do that again. I think it's been an eye-opener around the role and scope of practice for physios and how they can support really good general practice medicine. So thanks for that. Scott did a winner presentation around his role as a paramedic, and all of our ambassadors, Judith, Joanne and Scott, are all available to contact for advice, support and whatever. And as Natasha said, we're really keen to get your feedback. So what worked well, what didn't work very well, what do you want to hear more of? We would really gratefully hear that, because what we will do is flex the programme going forward to meet the needs of our colleagues out there. So please, feedback, that'd be great.
Thank you. And also, I'd just like to say a big thank you to Liam and Rob, who've been working really hard in the background, and also to prepare this webinar as well. So thank you guys for the seamless transition. I look forward to seeing you all on the 16th of February for the next instalment. Thank you and goodbye.
Thank you.
Thank you.
Good job, everybody. Thanks for your help. We did good. Well done.
I think that was really good. It was incredibly informative for me. And yeah, I think we just need to think of maybe ways to engage people better. I thought the first half was a little bit quiet. The second half was really good, wasn't it? You know, people were getting involved and stuff.
I think you need like pre-prepared questions for certain things like this. It's that first person to break the silence, and then all the other questions will just roll on and get the discussion. So you kind of need a ringer. That's the word, isn't it? Yeah.
You need a plant in the audience, is what we
need. That's it. Yeah. All right.
I think as well, there's probably been a lot of bombardment about physiotherapy, and there's a little bit more understanding about that. And maybe that's why there wasn't as many questions.
Okay.
Yeah. All good. I agree. Because they're already in post, aren't they? Right, I'm going to jump to the next one, guys. Thanks, Liam. Thanks, Scott. Thanks, Rob. Thanks, Judith. I'll see you all soon.
Yeah.
Well done, Natasha.
Thank you all for being involved. Scott, before you go, have you been snaffled to do the have you got him, Rob, to do the podcast?
Yeah. And you're a fan of them. Have you listened to them before as well?
Yeah, I have. Yeah, they're. I feel like I'm going to be starstruck. I'm going to meet them.
Because I've been dealing with them now for about 2 months, because I'm doing a GP fellowship, so they're doing stuff for us, and like the person that I deal with was the GP was like, I'm just gonna, when I meet them, I'll be starstruck. It's so good.
Yeah, no, the podcasts are absolutely fantastic. If you should just listen to them, because it's really widely kind of respected. I think I told one of our GPs, and they were like, "No way, as if you're going to be on that." So yeah, no, I'm looking. Yeah, I've booked in for next week.
They're really lovely and easy to talk to as well. They're so friendly, like. Because I didn't know them at all or know anything about it before I met them. I just knew about them. I've listened to a couple. I tried to listen to one of the clinical ones, and it was just like straight over my head. So I listened to like the ones about remote consultations and the stuff that you can transfer to a non-clinical environment. And it was quite interesting what I found. The psychology ones and mental health ones are there you can kind of grasp. But anything, I think it was one on headaches, and I was just like, no, just don't know anything about that.
I think I'd be the same, Rob, to be honest. Even being a clinician. And then the videos I'm keen to do. We just need to. I'll have a bit of headspace towards the middle of end of next month, I think. So maybe I'll watch the videos and have a look at see what you're after.
So have you asked them to do a day in the life? You got in there before me.
We did that ages ago. I think you mentioned it at the last.
Did I? If it was before Christmas, I can't remember. You know, I can only remember things from January onwards. But yeah, it'd be wonderful to have one of those videos, Scott. We're trying to build up a bank of them, so people can. It's really easy to sort of watch and see how you could benefit in somebody else's practice or whatever. So yeah. But thank you, everybody.
Thank you, and sorry for getting the slides to you late, Rob. It's
that's all right. No, that's fine.
Always last minute. I don't work unless I've got a deadline.
No, it was really good. Thank you. And yeah, I'm going to have a glass of wine now because.
Before you go, Natasha.
Right, I'll leave you guys. Take care.
Thanks, Scott. See you soon.
If you stop the recording, I think it'll process quicker. I think if you don't stop it, then it waits some time before
I'm pressing stop now.
It should just.
This meeting is being recorded. Are you sure you want to stop recording?